So Dr. Sushmita, please.
Good afternoon. Thank you. Thank you for the invitation. I apologize for the slight delay. Right. So we start with embryology of the anterior segment dysgenesis. And in the next couple of minutes, we'll see how does the angle develop? How do we recognize dysgenesis? Why does dysgenesis happen? How early can glaucoma develop? And what options do we have for management? So, childhood glaucoma is really like an ocean. It's similar. Once you've diagnosed childhood glaucoma, what next? This is the conglomerate that we'll be in. This is the CGRN classification. So, the primary glaucomas and the secondary glaucomas associated with non-ocular conditions or ocular conditions. So, non-acquired ocular, non-acquired systemic. So, this is the whole basket of clinical entities which are a result of these anterior segment dysgenesis. So, what is it and what is a normal infantile angle? So, the normal infantile angle looks like this. There's a flat iris insertion. The ciliary body band is usually present and it's a very translucent trabecular meshwork, though the stroma is not well formed. But then you have an iris, major arterial circle, and the radial vascular pillar. So, you can see that. And to see that, basically, you need a direct gonioscope. You need to turn the patient's head to the other side and then gently put the gonioscope on the patient's eye. And then you'll be able to visualize the nasal angle. And on the picture on top, you see that the microscope also needs to be tilted. And thanks to the MIGs, a lot of people have actually started doing this. So we hope it will translate into people also looking into the eyes and looking into the angle of babies. Coming to the normal angle development, what usually happens, and this is a busy slide, but at 5 months gestation, there's a continuous layer of endothelium which covers the angle. So this is what we are like. Now, this green thing is the trabecular meshwork, and this is the uveal tissue. So it's completely covering it. So there is no outflow. Basically, this is because the ciliary body hasn't developed and there's hardly any inflow. So there's no aqueous. So that's the protective thing, that there is no way that the fluid can go out. And then in the third trimester, the endothelial layer progressively disappears. It starts going back, receding, and then the peripheral uveal tissue begins to slide back, and development of the trabecular lamellae and intertrabecular spaces begins. So here, so this is the trabecular lamellae and intertrabecular spaces. But remember, there is continuous development of this trabecular meshwork till almost a year of age, and the normal AC angle is only formed then. The clinical significance of this would be in the fact that early lens extractions, because the lens, remember, is a regulator of trabecular meshwork dysgenesis. Right, so somebody's just changed the slide. Anyway, why are you changing my slides? नहीं, आई एम नॉट चेंजिंग, मैं कुछ नहीं कर रही हूँ इससे पहले. Right. So what I was saying was the lens is a regulator of trabecular meshwork development. And if you take the lens out early, then the trabecular meshwork development is arrested. Now, the clinical significance of that is in early cataract surgery, resulting in more glaucoma, the vitrectomy for ROP resulting in glaucomas. Now, once this has been recognized, the lens sparing vitrectomies have drastically brought down our ROP related glaucomas, as well as the IATS, which has come out with early cataract surgery or infantile cataract surgery prior to 6 months of age. So, most pediatric ophthalmologists, at least for bilateral cataracts, would like to delay it till about 6 to 8 months, and then the incidence of glaucoma is much less. So they're all related to the development of the anterior chamber. The other thing to remember is there is a development of outflow channels. So it's not enough for just the trabecular meshwork. So again, if you see this, this is just a Schlemm's canal is a 1 lumen at about 12 weeks. And then as the baby grows in utero at 26, 33, and 36 weeks, the outflow channels are developing. And they're finally developed only 2 months after birth. The other clinical correlate of this is why in neonatal onset glaucoma, if you just do a goniotomy, it doesn't work too well. Now, that's easy to understand if you look at development. They don't work too well because the outflow channels haven't developed. So, there's no point in just taking out trabecular or dysgenetic trabecular tissue. If they don't have a channel to move out, they're not going to work too well. So, therefore, the infantile glaucomas work so well. So, if you have a child who you're going to operate maybe at 3 months or 4 months or 6 months, those are the goniotomies, the garden variety infantile glaucomas, which are really going to work. So the neonatal onsets may not clear so well, but the infantile onsets are the one which you would want to target with doing just an angle surgery. So then what does the pathological angle look like? This is, remember, the normal AC. This is what the pathological angle would look like. Lots of iris processes which are covering the trabecular meshwork. And Sampaolazzi looked at a type 1 and a type 2 angle. Now, Sampaolazzi, this was at a time in the 60s when there were no gonio images, there weren't even microscopes. They used to operate with a handheld light and a loop. But even with that, he actually made drawings of every goniotomy that he did and asked a simple question: why is it that some goniotomies work so well and why is it that some goniotomies don't? So he took those children, he went back to his drawings, and what he saw was that in the children the goniotomy worked, the angle was something like this. So there was some trabecular meshwork, whereas those in which it didn't work, the iris hadn't receded at all and the trabecular meshwork was completely covered. So he classified that into a type 1 and a type 2 angle where the trabecular meshwork is visible and a trabecular meshwork is not. So it would be well within a logical consequence of this is to look at the angle before you do surgery. And if you have a type 2 angle, maybe at least keep it in mind that this is unlikely to work even if you're going to do a goniotomy, or maybe just plan an outflow procedure like a combined trap with trap. So, anterior segment genesis is a group of non acquired ocular anomalies with developmental abnormalities of the anterior segment where many genes, development of the ciliary body, lens, iris, cornea, everything is available, and the abnormalities affect multiple structures. And typically, they include combinations of iris hypoplasia, corneal opacity, and angle dysgenesis in a whole package. So these are the various combinations. I won't go into the details. This is the normal. Okay, so the underlying abnormality, usually in most of them, is genetic, and some of them have been mapped to different disorders. PITX2 and FOXY1 for Axenfeld, PAX6 for aniridia, and a whole lot of genes for Peters abnormality. Of course, there are overlapping clinical signs and genetic variants, and then there are mixed phenotypes. So, non acquired glaucoma stems from an embryologically abnormal trabecular meshwork, and it can manifest in myriad forms and multiple etiologies depending on the development, but genetic influences play a major role as well. Thank you.